We all understand that dental implants work well. And then there's always the big but. But there's some fundamental issues that we try to assess with this implant design and that we try to improve. And it all has to do with the resorption of buccal bone after implant placement. 5 years, 10 years, 15 years, 20 years. The longer you follow these patients, the more often you see this problem. And regardless of indication, meaning anatomic site, anterior, posterior, mandible, maxilla, it typically starts at the crestal facial bone, the bone loss. And then from there, it migrates apically. So if we take a CT scan of a patient treated 20 years ago and have to do some other implant somewhere else, and we look at our existing implant, a lot of them have bone loss on the buccal surface. And of course, there are a lot of factors that can cause this.
Those patients are usually orphans. Nobody owns them. Never happened, but it does. Now, some are surgical mistakes, all kind of mistakes. Some are maybe restorative issues, but some of them are just normal physiological changes that Peter has mentioned. You have it anteriorly. Well, ladies and gentlemen, you have it all over. You just have to learn where it comes from. So you have posterior throughout. It's just a question of time, the question of degree of resorption, and it happens to all our patients, and male and female. It's just not the aesthetic zone, but it's still the same problem. And it's on all implants.
So let's look at some design principles on what constitutes an ideal implant. And it's all about reserving bone. So what you try to do is increase the bone volume and soft tissue thickness. That's obvious. We place the implant for maximum bone volume while still being ideally restorable. And then the question is, what are we going to do with the implant designs? Are there any changes that we can do to improve the outcome? And this is then how the Nuventus implant was conceived, where we try to decrease the amount of titanium and create space for bone, because we know ultimately we need bone in order for the implant to survive long term. So what we have in this implant is we have a reduced diameter at the occlusal platform. It's kind of an egg-shaped occlusal platform that obviously needs to be aligned buccal-lingually. So this implant has orientation in that it's narrow buccal-lingually. And if you look at the way it's placed, this is a picture from Dr. Rosen illustrating the point, I think, quite beautifully, is the flat side is lined up with the facial of the buccal bone. And that gives us the most volume then for bone and subsequent soft tissue support. Okay, so the flat side aligns with the buccal and the lingual of the bone. And obviously the implant has a platform shift, and it has a rather big platform shift. So with the increase in the platform shift, we shift the abutment implant interface, which is always the crucial part in a two-stage system, more medially, and in order to protect the bone. And it's a combination of a machined surface, the ring around it, and a horizontal offset in a textured surface. So we know that this then subsequently will give us a stable tissue level. If you look at longitudinally, you can see the implant has clearly what we call the sine wave, significant reduction in the buccal lingual dimension. And this is, of course, in the interproximal, we have the full-size implant, but buccal lingually, we have more space for bone where it matters. And you can see, depending on where you are on the sine wave, we go from a 0.3 millimeter offset to more than a half a millimeter, 3/4 of a millimeter decrease in volume on the facial. That increases the bone volume subsequently, and that leads to much better long-term tissue stability. What we also incorporated is the cutting edges of the sine wave. We cut the cortical bone, if there's any, if it's not just a fresh extraction site. Sometimes we can engage on the lingual or palatal, but it generates bone chips and they get deposited directly into the space of the sine wave, as we've demonstrated earlier. So you can see here in the comparison, same size implant, regular platform implant, and in Nuventus, you can see the differences incise in the critical area of the implant. And that's kind of the design feature. If you look at radiographically, you can see now stability. We get at the apical portion on the facial. In the proximal, of course, you have threads full in a normal profile. Okay, and here a picture from Dr. Daftari and Sadeh, where you can see that even in reduced bone volumes, we're able then to maintain bone on the facial. If you look at our cases now for the past year, you can see that that bone, what we call the sine wave, the cutback, actually fills in with autogenous bone growing in. Okay, so if you look at the cross sections at the CT scan, always from the buccal to the lingual, the bone fills in beautifully in all the cases.
When you have a new idea or new device, the challenge is how does it behave in your day-to-day practice and how does it behave in extreme situations. What we'll show you today is placement of this implant in delay placement, immediate placement, placement associated with aesthetic reconstruction, immediate and delayed placement in the sinuses, placement around a veneer graft, cortical cancellous graft, immediate loading, in a complete reconstruct maxilla, and in a cleft palate where you have to be really accurate. So let's look at the first case, immediate placement. The implant is placed at first molar position, and months later restored. And then finally, you can see the response of the bone and the response of the soft tissue around the implant. Went further, look at delayed placement around the premolar. This is the ridge post-grafting. The implant, the 5 mm is placed. And again, with the sine wave. And the surprise again for us when we did the surgeries is the response of the soft tissue. For some reason or another, the soft tissue gets thicker. I can explain to you the fact that you get more bone, but it routinely changes the soft tissue dimension. In a severely resorbed mandibular ridge, both vertically and horizontally, and in a very thin biotype. We place the implant and it gives you already the hint of how the soft tissue will look. You can almost, those of you who do histology will say, you can almost see the hemidesmosomes there. And when we magnify it, it's stretched, yet it's gingival. And we look further, you don't need the grafting, which I think in many cases we do, but it illustrates quite a dramatic soft tissue changes circumferentially. Now, it's not like that on most of the implants that I see. And this is on a thin ridge, defective both buccolingually and vertically, with primarily mucosa, and this type of response. So we took it further, and again, the same response now in the first molar position. Granted, slightly thicker biotype. These patients with Peter, extremely narrow ridge, very narrow, very prominent incisive foramen, reconstructed it. This is how the ridge looks. Say, well, can we do it or can we not? And we use the Nuventus 3.5. Yes, we reconstructed with some autogenous in 3 layers, autogenous, allograft, and a xenograft, not to resorb. And that's before, and that's after, and which one is the implant? So, really tested it in all extreme situations.
A 40-year-old patient. This is a typical case that we encounter in our practices, whereby we have a horizontal fracture of a tooth, endodontically treated tooth. And my concern is, what do we do for that 40-year-old patient? It's about longevity. It's about predicting for the future. And Dr. Bahat has shared the literature with us about this standard of having 1.5 millimeters of buccal bone, but he so eloquently stated it doesn't exist in nature. So what we do here is we are very conservative in laying a flat, and we do an atraumatic extraction. And what are we left with? Nature. Teeth reside on bone. We're left with an extremely thin buccal plate of bone. So ideally, I want as thick a buccal plate that I can devise for the longevity of this 40-year-old female. Because we know that if we leave it as such, we're going to have resorption and remodeling. So here I place the Nuventus implant with the sine wave. The center photo illustrates the orientation of what it should look like when it's fully inserted, and then to the right, once it's placed subpressally, it's hard to see the orientation, but the flat surface should be to the buccal. And we put our healing abutment, we do a little bit of grafting. What do we have? 3.5 millimeters to the buccal plate of bone. We're setting this case up for success, not for today, not for tomorrow, but for the future. This is a case that I treated with the Nuventus implant system. This is atypical for my region. I'm in Boca Raton, Florida. To see edentulous arches is not prevalent, nor is it prevalent in even less so in a 34-year-old patient. So what are we going to do? We're going to provide him with immediate placement, immediate load, double arch restoration. We place our 12 implants, and this is what he looks like 2 days post-surgery. Very simple, straightforward, great thread design for great stability. Here's the case. Of course, the implants are not placed to depth. This is to illustrate the flat side of the implant, such that when it's placed to full depth, that is oriented in such a fashion. But let's take a look at this lower arch. Look at the benefit of having this implant design that gives us that much more space from the buccal plate. So once we graft it, we know we're going to have a lot of long-term stability as such.
I like the rounded apex design of the implant. It doesn't have aggressive threads right at the apex or cutting threads that once you get close to the sinus, you just tear up the Schneiderian membrane. It's like a bullet, it's rounded. At the top, that then allows for the lifting of the Schneiderian membrane. And you can see here, this is how the implant looks immediately after implant placement. The Schneiderian implant is lifted. There's space under the membrane, and there's space mesio and distal of the sine wave. No, we didn't use any bone grafting in this case. And upon restoration, look how this looks now. Huh? We know under the Schneiderian membrane, the space will fill in with bone. That was expected, but look at the amount of ingrowth into the sine wave we have that is not related at all to grafting. It is just natural bone apposition.
Well, then sometimes, like in cases where the molar has drifted mesially, you can use the sine wave in a mesiodistal direction. And Peter will show it to you later in a few cases. So if I'm too narrow, because 17 is moved mesially, we can create the sine wave on the mesial and distal as opposed to buccal and lingual. So it gives you options in a narrower space as well. And that's exactly what we did here. And again, the bone case is reconstructed, the bone is all the way to the top, and the soft tissue follows.
So in conclusions, the implant should be biologically driven and designed for long-term aesthetic results. So what we learned over the past 40 years is that where we place the implant with the situation that we had, chances are 20, 30 years later, things have changed dramatically. So we treat and plant things differently, and we use different implants that accommodate for the biologic changes that we see happening to any implant or any patient long-term. Clearly, the sine wave profile in the buccal area increases the bone volume, all other things being equal, while having the same load-bearing capabilities and everything else. And if we have an increased bone volume, we have better soft tissue response today, and we protect the implant long-term from resorption.